Today we're focusing on one aspect of the practice of anesthesia, the use of opioids. We'll talk about their advantages and disadvantages and tell you what you need to know to assure the best outcomes for every patient every day. We're broadcasting live from the VHA TV studio in Irving, Texas. Let's get started. Opportunities for improving perioperative care have never been more urgent and more challenging. Perioperative patient management hinges on providing adequate pain management, as well as using anesthetic agents that are safe and appropriate for the type of surgery a patient will receive. Today, we'll focus on the use of short-acting opioids and describe some of the concerns about them, including drug accumulation, respiratory depression, postoperative nausea and vomiting, and unpredictable recovery times. Also, we'll examine how inhalation-based anesthesia compares with total intravenous anesthesia using short-acting opioids. Here are our learning objectives for today's program. After viewing, you'll be able to discuss the considerations for perioperative anesthesia with short-acting opioids, examine the pharmacokinetic and pharmacodynamic effects of available short-acting opioids used in general anesthesia, and describe the advantages and disadvantages of short-acting opioids as part of a general anesthesia regimen. We hope you've had a chance to download the event materials from our website. In them, you'll find the supplemental information for the program that our faculty have shared with us. Let's meet them now. First, joining us is Dr. Adam Levine from the Icahn School of Medicine at Mount Sinai in New York City. Adam, we're thrilled you're here with your expertise. Tell us a little bit about your background.
Well, thank you, Lily, and I'm glad to be here. And I'm a full professor of anesthesiology. I trained at Mount Sinai from 1990 to 93, and I stayed on faculty since 1993 and took over running the residency program, and I've been the residency program director since 1996. And I'm proud to say I get to educate and foster the next generation of both medical students and anesthesia providers. And it's a thrill to be here. Thank you.
Noble job, noble profession. Thank you. Also joining us is Mark Antoszyk. He's a nurse anesthetist at Carolinas Medical Center in Concord, North Carolina. Mark, you have quite a storied background as well. Tell us about it.
Yes, I've been the chief nurse anesthetist now for 10 years at Carolinas Medical Center Northeast in Concord, North Carolina. I've been a CRNA since 1987. I've been a nurse since 1981. During that time, I was also a police officer, retiring in 2002 after 25 years as a police officer. I'm an instructor in basic life support, pediatric advanced life support, and advanced cardiac life support.
Well, we're so glad you're here. Now, Mark, let's start with you. What do you need to know? What do you do before you're even beginning to administer anesthesia?
You know, we do a pre-operative evaluation on the patient. It's our opportunity to build a rapport with our patients at that time. It's important that we find out their history and physical. What's going on with them? Do they have any additional disease processes that we need to know about? You know, do they have a history of muscular dystrophy, a history of Mylan hypothermia in the family? Have they had anesthesia in the past, and have they had any problems with it, or anybody in the family that have any problems with the anesthesia in the past? You know, have they had a prolonged anesthetic or delay in awakening from a previous anesthetic? What are their allergies? We'll assess their airway, make sure that they have an adequate airway. Do they have a history of sleep apnea? And from that, we'll put it all together and then determine what is the best anesthetic for them for that surgery that they're going to have. And what is the expected outcome post-operatively for them as well.
And you know, Adam, in this high turnover OR, this is an important step that can't be skipped, right?
This can't be skipped, and I think it's easy for many medical educators to diminish the role of communication skills and the relationship we develop with our patients. It's very intense. It's at the most critical moments. It's during a stressful time in the perioperative period. And it's that time that, as I will echo what Mark said, it's that rapport that we're going to develop with the patient. We are just meeting them. They're entrusting in their lives to us. They have to develop the sense of comfort and appreciate that we have their best interest in heart. But during that process, we are gathering information and formulating a plan that is going to be tailor-made to their individual needs and the individual needs of the particular surgery that they're undergoing. It's a 10, 15-minute time frame that a lot is actually going on.
So, and we're going to be referring back to how important this assessment is in the beginning throughout the program, but individualization is what's key. Now, there are a lot of trends that are impacting us. It feels like the Affordable Care Act, cost reduction, do more, better, quicker, faster. What about specific trends in anesthesia we should know about?
Yeah, I think specifically the trends in anesthesiology is reflective in the general practice of medicine. And as you've already alluded to, we're after patient safety, error reduction, better outcomes, but in an efficient process. Specific to anesthesiology, that actually sort of boils down to better educated practitioners, a better use of monitoring, and fortunately, the industry has supplied us with better pharmacologic agents so that we can employ those to best care for our patients.
And we've got a bigger, sicker, aging population that needs better pharmacology applied, right?
So it's pretty clear that in the last 2 decades of my practice, what has really morphed and changed is that we are expected to take care of, at this point in time, there's no one considered too sick or too old to undergo a surgical procedure, no matter how invasive and how complex. Yet, as practitioners, as providers, anesthesiologists, CRNAs are expected to carry those patients through a very critical, very artificial environment of the operating room without any morbidity and without any mortality. We're almost falling victim to our own successes as a profession, and it's expected to continue. And we keep providing further care for the most sick and patients.
So the stakes just keep getting higher. We can't do today's procedures with yesterday's drugs.
No, and in fact, we've reduced morbidity and mortality despite the sicker, more complex surgeries.
That's the good news.
That is the good news.
That is the good news. But just for level setting here, we've used opioids in surgery and in anesthesia for a long, long time, right?
No question. We're talking decades and decades of use. It's clear that the opioids impart a significant advantage to our patients. That advantage is the reduction of the needs for other agents. It's also clear that the opioids will impart cardiovascular stability on our patients. It'll reduce the stress of surgery, both from a sympathetic discharge point of view and neuroendocrine pathways. So we'll have less tachycardia, less hypertension, less hyperglycemia, perhaps reduce the entire inflammatory process, ultimately providing a patient with a safer intraoperative and therefore a better postoperative course.
Great, thank you. Mark, let's move to you now and talk about short-acting opioids. What's their role?
You know, the short-acting opioids have really transitioned over the last 20 years as we've transitioned to more outpatient anesthesia, even on the inpatient world, where we're trying to turn cases over quickly. And these opioids you can use to decrease your MAC, and they're now like L-fentanyl, remifentanil, fentanyl, and sufentanil. They've all transitioned to help us with outpatient surgery. The newer, shorter-acting opioids, they're more titratable. They got a more rapid on and off set for timing, so I can transition my patients quickly from a really deep opioid-based anesthetic to shut off and they're awake. They reduce respiratory compromise, they improve emergence and recovery, they decrease the risk of post-op adverse events, and balanced anesthesia techniques with short-acting opioids have a place in our operating rooms and may actually increase patient safety and satisfaction.
At least we hope so, that's for sure. Adam, he just mentioned the 4 short-acting opioids in use today. How do we differentiate between them?
So when we're talking about the main 4 intravenous opioids that Mark alluded to, fentanyl, sufentanil, alfentanil, and remifentanil, the class of fentanyls, the piperidine analogs, they all bind to the same receptors. Those are the mu receptors. That's our goal and objective. Mu1 receptor binding actually imparts the analgesia. Whenever we want to employ a drug, opioids are going to be one of the mainstay drugs we're going to use to decrease painful stimulation, both perioperatively, that includes pre, intra, and postoperatively. So the end result are all expected to be similar for the 4 different agents. What makes them novel is their pharmacokinetics, their onsets, their offsets, and their routes of elimination. And it is those unique principles, if we go back to basic pharmacology, it's those principles that really are the guiding force of how one, with knowledge and judgment, can pick a specific opioid and tailor it specifically because of its onset-offset times to the particular surgical case and the particular patients that we're managing. Here on the slide are principles of pharmacokinetics that we're talking about, and listed here is alfentanil, remifentanil, fentanyl, and sufentanil, and 3 parameters that practitioners who are using these drugs really need to be familiar with and facile with the information. The 3 parameters that are used to determine onset and offset are volume of distribution, pKa, and clearance. You'll notice that fentanyl and sufentanil have very similar volumes of distribution and pKa. pKa is that pH when you have 50% ionized, 50% non-ionized. And with the same volume of distribution and pKa, fentanyl and sufentanil have the same onset times. They peak effect in about 3 to 5 minutes. Alfentanil and remifentanil have small volumes of distribution. That keeps the plasma level high, supports a gradient of plasma to central nervous system, which is where we want our drug to arrive and bind to the mu receptor. And those drugs, with the limited volume of distribution, have a sustained plasma central nervous system gradient. Their preferential beneficial PK also imparts that when injected to the body, 90% of that substance will remain non-ionized versus fentanyl and sufentanil, which will be 90% ionized. That non-ionized state also crosses the blood-brain barrier very rapidly. Both alfentanil and remifentanil have similar peak effects in about 60 to 90 seconds. Now, when you're comparing 60 to 90 seconds versus 3 to 5 minutes, in most practitioners' hands, that might not seem like a big deal.
But it is a big deal.
It is a big deal. In the operating room, there's acute events that are occurring, and we're talking magnitudes of speed of difference. And that speed of onset really is advantageous to titratability. The other unique aspect of, and specifically remifentanil, if we go back to that slide, remifentanil has a very large clearance, magnitudes greater than both fentanyl, sufentanil, and alfentanil. Because of its clearance, it also goes away very quickly. So the small volume of distribution, the large clearance means it's beta elimination, the true half-life, the amount of time it takes for half of it to dissipate is magnitude smaller and shorter than the other drugs, which imparts a lack of accumulation. It affords us titratability. And it's that offset that also makes that particular drug exceedingly unique in the class of those 4 drugs.
What about metabolism of hydrolysis that we've talked about?
So what makes remifentanil's clearance so large and the volume great is because it's uniquely ester hydrolyzed. It's been engineered to have a susceptible ester, which gets metabolized by nonspecific tissue and plasma esterases in our body. The metabolite of which is essentially inert. It's 1/4600th the potency of the apparent compound. So the metabolite has no more effect. This ester susceptibility or ester hydrolysis susceptibility imparts remifentanil's unique characteristics. Its organ-independent route of metabolism means that it's not attached to genetic predispositions, gender bias, or gender issues, organ failures, kidney, liver failures, which would prolong the effects of our other drugs. And as we're taking care of more complex patients with sicker and sicker comorbidities, we have to consider these in our regimen when we're planning our anesthetic.
Really important. And you talked about half-lines. You have a great slide about context-sensitive half-time, if you'll talk about that.
Yeah, this is a critical component when we're talking about intravenous anesthetics and certainly infusions. And it behooves all of us to learn infusion techniques. It prevents the peaks and troughs of bolus administration of anesthetics. And here we have a slide. It's called the context-sensitive half-time of the 4 major IV opioids. Now, context-sensitive half-time is the time it takes for 50% of the plasma level to be cleared after a steady-state infusion. You'll notice that fentanyl, which we all use, and we've all used successfully at about 1 to 2 mics per kilo per hour, or about 100 mics per hour, we've all set that in background on an infusion, and we've all had some real reliable, good results. However, does not have a beneficial context-sensitive half-time. The longer you infuse it, the longer it takes for 50% to go away. And you'll see here on the pink line, at about 100 minutes of infusion, it takes about 100 minutes for it to go away. Alfentanil, sufentanil, the longer you infuse, there is some plateauing, but the longer it also takes to go away. But they have some beneficial intermediate context-sensitive half-times. What's novel is remifentanil, in that no matter how long you use the drug and no matter how long you infuse the drug, the context-sensitive half-time, which is what will impart the true clinical half-life, is sustained at about 3 to 4 minutes.
I want to really concentrate on the advantages and disadvantages of rapid onset. You kind of mentioned that, but walk us through advantages and disadvantage of rapid onset.
Okay.
Why is this important?
Titratability is really what's important. In our operating rooms, things are happening at a fast pace. We can, most of the time, we don't want to play defense. We want to play offense. We can anticipate changes in our environment, and with those anticipations, we know the timing it's going to occur. And it's wonderful to have a drug that is reliably peaking at the time we want it to peak. And that all sounds fantastic. Inject a drug, be able to tell to the surgeon, go for it. We're ready. We got a nice level,
you're ready.
and we are ready. We know we're ready.
Yeah.
69, very reliable, fairly unwavering, etc. However, nothing's free in the world. With a rapid onset, means that the plasma level rises rapidly, which means that the central nervous system level rises rapidly, which means that the binding to receptors and the effector site rises rapidly. All of the bad side effects, which can be life-threatening, the severe bradycardia, the hypotension, the apnea, the unintended apnea, if our patients were expected to be breathing, they won't be shortly, and what's called the chest wall rigidity or laryngospasm, difficult to ventilate, are more likely to occur at a higher rate with this rapid onset bolus fashion.
And what about rapid offset?
So again, that sounds fantastic. Be able to shut something off and it goes away, and reliably. We all say, and every anesthesia provider will say, that anesthesia is not an exact science, but some of these very engineered drugs give us the tools for it to be an exact science. Unfortunately, or fortunately, one has to anticipate that the rapid off means it's off. And if you expected residual effects like the other opioids, you're not going to have it with this particular drug. And that's fine if it's anticipated. And again, anticipated off means that there has to be an opportunity that you have to, if there's going to be anticipated pain at the end of the procedure, one has to bridge the transition from the anesthetized intraoperative state to the postoperative period in a smooth fashion, and we need to think about other modalities for pain management. However, always keep in mind that there's the unanticipated, the IV disconnects, the pump fails, the IV infiltrates. If you're not aware or on top of your game and you miss that window of opportunity, you can find your patient destabilized, tachycardic, hypertensive with inadequate opioids because the drug will essentially dissipate in a few minutes.
Yeah, just from a human factor standpoint, always on top of your game is the name of the game here.
Absolutely, which
right.
should be that is the name of the game. That's part of what we're all sitting here, trumpeting our successes, but it's because of the physicians that are involved in and CRNAs that are involved in providing anesthesia care in this country.
That's exactly right. You mentioned pain management and rapid offset and what might happen. So go a little bit more into the advantages and disadvantages.
So certainly if we don't bridge the use of, remifentanil is really not a substitute for fentanyl. It's used to substitute the general anesthetic drugs that we're using intraoperatively. And one can't consider that if there's going to be pain, there has to be methodology strategies to be employed during the procedure that is used to bridge the transition to a wake state with good postoperative pain management. That includes a variety of methods, and many of us are using multimodality methodologies, which includes using longer-acting IV opioids, including fentanyl, sufentanil, or morphine, infiltrating with local anesthesia, using IV NSAIDs like the new acetaminophen or ketorolac, activating an epidural, having employed a regional anesthetic technique either before the patient went off to sleep or intra. I do a lot of head and neck, and we actually novelly use a lot of regional anesthesia techniques for sinus, thyroid, parathyroid surgeries, and I don't use any long-acting opioids in my practice. We use the short-acting drug intraoperatively and bridge with a regional anesthetic technique for postoperative care.
So quick onset, quick offset. Talking about pain management, which is so important, Mark, what about nausea and vomiting? Any differences? Do short-acting opioids affect NNV at all?
No, I don't think just because they're short-acting opioids, it's going to decrease your NOV. So my answer would that be probably no. You still have to look at the patient. You're going to have increased incidence with females, increased incidence if they have history of motion sickness, or they've had post-op nausea and vomiting before, that they're non-smoker, they're young at age. Duration of or use of volatile anesthetics, surgical type, all play into their nausea and vomiting. And opioids also play into their nausea and vomiting as well. So you still have to use multiple modal antiemetic drugs to help prevent nausea, post-op nausea and vomiting with your patients.
This one that's going to be around for a while. So with a patient that has a history of nausea and vomiting, where would you make the decision whether to use TIVA or inhalation technique?
For me, if they have a history of post-op nausea and vomiting prior and they've had inhalation agents before, or it's a surgery that I really can't afford them to be sick afterwards. It's head and neck surgery, somewhere where I don't want them retching afterwards. I will then look to use TIVA. The use of propofol along with my short-acting opioids decreases my incidence of post-op nausea and vomiting along with my other antiemetic drugs.
And Adam, when is there a place for inhaled anesthetics? Though they've been around a long time.
I know we've been focusing on TIVA and the opioids, but it's clear that the inhaled are here to stay. They've been used reliably for a century and a half. They're cheap, they're easy, they're titratable. I think also, very importantly, that you can monitor the depth of anesthesia using expired gas analysis and looking at percent MAC of administered anesthetics that you cannot use or you cannot achieve with intravenous anesthetics.
So a place for both. We have two quick questions here. Do you need a TCI to dose remifentanil?
So TCI, targeted controlled infusion. There's a lot of talk. It's first of all, it's not even available in the States. The beauty about this drug is that you actually do not need TCI because it doesn't accumulate. Based on the infusion rate, you know the precise plasma level, which also equates with very rapidly the effector level, and therefore you can predict the pharmacodynamic effects very reliably. And it's actually the drug that doesn't require a TCI to manipulate.
So good question. Here's another one. How do we go about deciding to start a total IV anesthetic? This is part of that individualization, or?
Again, I think it's individual to the patient and what your outcome and the procedure. If it's a type of procedure where maybe even inhalation can't even be used, it may be that they've got some airway issues where you can't actually put an endotracheal tube in or breathe them down, your choice may be a TIVA type or even a monitored anesthesia with sedation using TIVA type medications of propofol and short-acting opioids.
So the type of patient, the type of procedure is going to limit us.
Cool.
To add to our discussion on anesthesia practice, we recently interviewed an anesthesiologist in CRNA who discussed their approaches for general anesthesia and their views on the use of opioid-based agents. Let's take a look.
There are two main inhalational agents that I use now, Sevoflurane and Desflurane, and in addition to nitrous oxide, which is just like an adjunct to the other primary volatile inhalational agents. Sevoflurane is relatively short-acting. It breathes off fairly quickly agent. It doesn't require a high concentration in order to work, so you can give fairly large amounts of it without affecting the actual amount of oxygen delivered to the patient. It does have some drawbacks. It's slower to come off after a longer procedure than something like Desflurane. It tends to hibernate out in the adipose tissue. So especially on larger patients, if on a long procedure, it takes a long time for it to breathe off. Desflurane also requires higher concentrations than Sevoflurane, about 6 to 8% for 1 MAC of anesthesia. So if you're with a patient that is relatively refractory to the inhalational anesthetics and you have to give more, Desflurane's not the best choice because at higher concentrations, it uses up more of your gas space. If you're using 8 to 18% of that agent, that's going to adversely affect your inhaled oxygen concentration.
Desflurane is a pretty noxious stimulus to the tracheobronchial tree. So you have to be very careful with patients when you're trying to do either mask inductions or gentle inductions with Desflurane, because they can get in trouble quickly with bronchospasm or laryngospasm. Desflurane also can occasionally raise a patient's heart rate and they can get a sympathetic response. Sevoflurane, on the other hand, in my practice is a much smoother agent. It's much easier on and off. Going back to the advantages of Desflurane, it is very quick on and off, and that's one of the reasons you might want to use it. I use that agent frequently for cases that are longer, and especially if you have obese patients and you don't want the inhalational agent to accumulate and you want the patient to exhale the agent quickly at the end of the case, then Desflurane is a faster agent for that. There are times when it's appropriate to use a completely intravenous anesthetic, which we refer to as TIVA, total intravenous anesthetic. If a patient has a history of malignant hyperthermia or any sort of suggestion that they might have a family history of malignant hyperthermia and you want to stay away from any of the triggers, the known triggers, even though they're very rare, it's still possible to trigger MH with inhalational anesthetics.
It's good for certain things, like we do a variation of TIVA, like with colonoscopies even here, where you combine a benzodiazepine like Versed with fentanyl or some other opioid and propofol. And though the patient remains breathing on their own, still, all their anesthetics provided intravenously. It's good for short procedures where you don't need intense anesthesia. It's also good as an adjunct to inhalational anesthesia when you can't give large amounts of the volatile anesthetics like spinal surgery. A lot of times you can give something like propofol or a short-acting opioid like remifentanil as an adjunct to the inhalational agent while they're doing the neural monitoring. Opioids, in general, most of them are respiratory depressants. Also, if you give too much of some of them, they can cause chest wall rigidity and some other undesirable things.
They increase the chance of postoperative nausea and vomiting. You can worsen a patient's delirium or confusion state. They can also have an itch response to narcotics, get pruritus. And then depending on which narcotic you use and how they respond to it, and each individual has their own response, you can end up with a prolonged recovery period.
The upside of that is they do lower the heart rate, which is a lot of times desirable since surgery is a painful stimulus and it causes the heart rate and blood pressure and respiratory rate to often rise.
The reason for using opioids is to decrease the entire stress of the surgical process, from induction, intubation, the surgical stimulus from top to bottom, as well as pain relief. The whole intent of opioids is to reduce the stress and to decrease the amount of anesthetics that you need to use other than the opioid. They create kind of a background of a balanced approach to anesthesia.
The background to a balanced approach to anesthesia. There are so many agents to use. What was your opinion after you saw the video?
I mean, I think like many of the people in our audience, they recognize that we have a large arsenal in our armamentarium of pharmacopoeia that we can use in our patients, and we're going to tailor our anesthetic specifically to our individual patients. And it behooves us to be knowledgeable and understand the indications and potential contraindications of all of our techniques. And each technique, you can use different agents. And having a broad palette of which to pick just means that you're a more facile provider for the unique patients that are going to be coming down into our operating rooms.
It's all about individualizing care. Mark, what did you think?
Again, just like the anesthesia provider said, they individualize their choices for their anesthetic, and it's just part of the anesthesia that we do. We put all the pieces together in our mind, what the patient tells us, what the surgeons need, and then we design an anesthetic that's going to be successful for that patient.
So important to standardize excellence, individualize care. Let me ask you, Adam, why would we even want to use a short-acting opioid when you hear about all these agents that are available to us?
It's pretty clear. I mean, most people, in my entire experience, those that have received this drug, it's titratable, it's predictable, it doesn't accumulate. I can use it on a variety of different patients. And most importantly, it's I can predict the level of analgesia and response that I'm going to get in some of the most critical of patients. Uniquely, we're not all perfect, and although we like to think that we're all expert, surprisingly, we don't always get it right. Sometimes we underdose and our patients become tachycardic and hypertensive. Sometimes we overdose and our patients aren't waking up at the end. There is something empowering about a pharmacologic agent that if I need to give more, I can, and still reliably titrate it to the individual needs of my patient. We're really guessing at, even though we have a very scientifically based drug, we're guessing on the unique response from any individual patient. And it really is empowering to have a drug that allows us to titrate to the individual needs.
So patients are unpredictable. It helps when the drugs are predictable.
You couldn't have said it better, thank you. Or I couldn't have said it better. And I'm going to quote you on that.
We've all been in that place. I want to move to costs for just a moment because there's always the good news, bad news. We are in an era of tenacious cost reduction, but also an era of value because of transparency and more of what we do being very open to consumers. So who wants to take a cost thought first?
I think a lot of times we look at the cost as just a single vial cost or a single bottle of anesthetic gas, what it cost. But even our opioids, when we administer them, they're for a period of time. They're not just immediately give and it's gone. Fentanyl, we're going to give some fentanyl at the beginning of a case and it's going to be good for an hour, 2 hours. I give remifentanil if I put in and start an infusion. That infusion may last up to 3-4 hours. Decreasing my MAC of my other anesthetic agents, which would then decrease my cost. At the same time, I'm having my patient maybe emerge quicker. I can move them out of the ORs quicker, and we got to move cases in the ORs to be able to make money for the hospital facility. Plus the demand's there. We're going to have more demand for our OR space. So I got to be able to wake my patients up, get them to the PACU, and move them through the PACU, and not have a backlog there.
So
and
you can increase room turnover?
Absolutely.
More predictably?
More predictably.
I mean, it's pretty clear that it's really easy to say that one particular drug costs more than another particular drug. But it's also clear that with the use of opioids and the use of neuromuscular blockades, we're having if we allow the patient to have residual effects of both of those drugs, we have post-operative respiratory problems, which no one could put a price tag on. Or if we have to sustain the patient with an endotracheal tube on a ventilator in an ICU, we're talking about cost incurred. The use of ultra-short-acting or short-acting opioids like remifentanil negate the need for neuromuscular blockade and also allow for a more titratable opioid for post-operative pain, as opposed to guessing what the patient's going to need in the operating room and getting it wrong.
Oh, yes. Okay, we've discussed why a particular agent may provide an advantage over another and why a particular technique may be chosen. Now let's talk about how it can be applied in practice. Adam, can you talk about some scenarios where TIVA may be an advantage over inhalation-based anesthesia, or even vice versa?
Sure. Look, And this is based on I've been practicing now since 1993. The principles that I use today are basically some of the principles I learned even in my training from 1993. And patients respond better to an IV-based anesthetic in my mind. And my practice has morphed into, I care for mostly ENT patients. With that, I do a fair amount of sinus endoscopy, base of skull surgery. It's fairly clear from the literature that an IV-based, remifentanil-based anesthetic has clear advantages for intraoperative conditions. That means decreasing blood loss or bleeding into the surgical field when surgeons are working endoscopically in the sinus or at the base of the skull. That decreased blood loss shortens operative time, decreases risks of traumatizing surrounding structures, such as the eye, the carotid, the brain. And it is even clear that remifentanil exclusively, because the dose that can be used to achieve a controlled hypotensive or cardiac reduction capability due to bradycardia, has advantages over fentanyl, sufentanil, and alfentanil. It's also clear that this drug is antipertussis, which means that I can predictably emerge a patient on a predictable level of remifentanil and avoid bucking, coughing, and respiratory depression post-extubation. So I can emerge them awake, alert. No longer do we have to entertain the idea that we're going to do a deep extubation on a patient that just had head and neck surgery.
Is there any other drug that allows you to do that?
All the opioids have the potential, but not as reliably and as predictably, especially in someone with a potentially compromised airway.
What about other cases besides ENT?
So it's clear that there are true advantages in neurosurgical cases. That's the other mainstay. In fact, before I became an ENT anesthesiologist, did a lot of neuroanesthesia. Monitoring has become the mainstay of both intracranial and spinal surgeries. That's SSCP, motor evokes, et cetera. Those are greatly diminished, and the ability to monitor those cannot be done with a predominantly inhaled-based anesthetic. And TIVA really is indicated. It's also clear there's huge advantages of a titratable anesthetic to be able to assess the neurologic patient for neurologic sequelae, both after intracranial or spinal surgery.
Mark, what about the obesity population that we're having to deal with more and more? We have a big aging population, but we have a really large obesity population.
Yeah, I think that's another place where these short-acting opioids would come in place, and maybe not necessarily TIVA. A lot of bariatric cases, they're really promoting more like Desflurane, but you still need, and you can't use nitrous oxide with those cases. So you're really looking for something to give these patients analgesic intraoperatively, but you don't want to have residual narcotics on board trying to wake these patients up for the PACU. Mm-hmm. So the bariatric population, where you could use something like remifentanil, and you're using their ideal body weight to give them that. Other cases like sleep apnea, things where you don't want residual opioids, or you want to be able to titrate your longer acting opioids in fairly with a fresh patient, where because something like remifentanil, you shut it off, it's gone. You now can titrate in morphine or Dilaudid, and you're dealing with a pretty fresh patient narcotic-wise.
Absolutely. So we're aware of some of the risks with short-acting opioids, such as chest wall rigidity that we've talked about. Talk about dosing strategy to optimize patient safety.
Well, I think that's where titrating a medication comes in, and understanding your opioids and how to titrate them in. And let me use remifentanil here as an example, because you can titrate in your remifentanil, and as you can see, just by not even giving a bolus, but just by turning it on and adjusting your infusion anywhere from 0.1 to your general dosing of 1.0 mics per kilogram per minute, you can see how quickly it rises. And you can then titrate your drug in to make it work where you want it. If you don't want to see rigidity, then you're not going to take it up to 0.5 or 1 into the general dosing unless you're planning on using some type of neuromuscular blocker. But if I'm staying around 0.1 mics per kilogram per minute, you can see I can get analgesic effects, because all I need is between 1 to 3 nanograms. And on the slide there, you can see I'm there within 3 minutes.
Wow. What about boluses?
Yeah, I prefer to bolus. I mean, I'm aware that the likelihood of getting bradycardic, hypotensive, the potential of chest wall rigidity, certainly apnea, we're going to be concerned about in MAC cases. We'll talk about that in a little bit. But I love the idea that I can give a drug, and in 60 to 90 seconds I know the peak effect. I don't necessarily want to wait for my infusion to reach a peak effect in 3 to 5 minutes with the new onset of a new steady state. So yes, I like bolusing, but there are ways of ameliorating the potential problems by giving more drugs that support the blood pressure, the heart rate, or using neuromuscular blockade to avoid the chest wall or the laryngospasm that we're alluding to.
Helpful. Mark, what can you tell us about the utility of TIVA for applications such as monitored anesthesia care?
Yeah, this is another drug, your opioids, that you can add to your sedation package for monitored anesthesia care. And you can titrate in things like these rapid opioids like remifentanil, where you can actually start at 0.1 mics per kilogram per minute, titrate it up according to what the respiration rate of the patient is, add in your benzodiazepines or add in your propofol, and you can put the patient into a nice mild sleep and be able still to maintain the respiration rate, but also titrate it according to pain or discomfort that the patient may be having. So if you've introduced a block into the patient and it's not successful, you may be able to prevent general anesthesia by introducing remifentanil sedation for your patient. So
you gave us a graphic about infusion rates for max sedation we want to make sure we refer to for people in their handout.
Correct, and with this slide you can see also I use this max sedation rate for my general anesthetics as well. And that's how I can prolong my cost with my remifentanil. I usually run my patients around 0.1 mics per kilogram per minute to start, and you can see within 3 to 5 minutes, even up to 6 minutes, I'm into my analgesic effect, I'm into my respiratory depression area, but if I titrate it down, if I'm doing MAC anesthesia, start them at 0.1, get them to the level I want, reduce them down to 0.05 or even down to 0.025, I'm still in my analgesic area, they're breathing spontaneous. But I can also do this same dosing for my general cases and give them the analgesic they need to be comfortable throughout that surgical procedure.
Absolutely. What about polypharmacy, Adam?
So when I'm doing a MAC case, I actually avoid polypharmacy. And obviously, when you're planning any case, you have to figure out your goals and objectives. And for most of my procedures, they're going to be around the head and neck. And I'm very concerned about supplemental oxygen and the risk of fire in the operating room. And the accumulation. So my goal and objective is to minimize the respiratory depression. I know that sounds contradictory to the opioids, but if you avoid polypharmacy and avoid benzos, hypnotics, along with your opioids, and just stay with a clean opioid MAC, patients tolerate noxious stimuli. That's why we're there. That's most of the time. If it's not unpleasant, they're not anxious. And we can get away with the idea of having the synergistic respiratory depression. For most of my MAC cases, I'll either use straight fentanyl or, again, using the MAC level of remifentanil, which is a 1 mic per kilo bolus, followed by a 0.1 mic per kilo per minute infusion. That gives me analgesia. If, however, the patient does require, again, tailoring it to the individual patient, a hypnotic, I'm going to reduce that bolus dose and that infusion dose, appreciating the respiratory depression. It's clear that the most important monitor when doing MAC cases with opioids is the end-tidal CO2 monitor and a respiratory monitor.
Great. I know we've got questions rolling in and a lot of content yet to go, but I still think it's very important, Mark, especially since you're a nurse anesthetist, to talk about, are there any nursing considerations that we need to think about intraoperatively or in the PACU?
Intraoperatively, if we don't pre-plan well enough for our postoperative pain and the patient has pain, they may wake up kind of restless. In the PACU, even though we use the short-acting opioids, there's still the chance of respiratory depression. And if we've added some longer-acting narcotics for postoperative pain control, or even regional on top of some narcotics that they've already received, they have a chance of respiratory depression. So patients still need to be monitored closely by the PACU nurses.
Thanks, Adam and Mark. I want to get to some of the questions that are coming in, but first I want to make sure that you can get involved in our conversations. And remember, there are 3 ways that you can join us. For our web viewers, select the Ask a Question button, then type your question and click Submit. Or send us an email, which you're doing right now, at vhatvlive@vha.com, or call us at 800-565-8107, and be sure to press *1 to ask a question. Now let's get to a few questions we've already received. How do you deal with propofol shortages?
Simply, the way I deal with propofol shortages is I reduce my level of propofol using opioids, whether that is whether it's with sufentanil, fentanyl, or remifentanil. I can reduce the dose. I know we've talked a lot about balanced anesthetics and TIVA. I do a balanced anesthetic, and this might sound heresy, but I still love nitrous oxide. I find that drug, I can substitute 3/4 of a MAC of anesthetic, 70%-ish of nitrous oxide, which allows me to reduce my propofol to approximately 20 to 30 mics per kilo per minute. And I've avoided the concern of propofol of shortages by using other agents.
Any comment?
No, I agree.
Okay.
I agree.
What about hyperalgesia? How do you respond when using a short-acting agent quickly?
So that's very controversial. You can look in the literature, and I think there's enough literature to suggest it has an impact, and that giving intraoperative opioids might cause hyperalgesia, which means that the patient needs larger doses of opioid postoperatively for the same analgesic properties. It's also clear that it doesn't matter what kind of opioid being used, whether it's morphine, fentanyl, remifentanil, alfentanil, sufentanil, and whether it's intravenous or intrathecal. They've all been associated, perhaps, with this concept of hyperalgesia. The jury's still out. I think it's clear, though, if you use any other drug, whether it's propofol, nitrous oxide, sevoflurane, all of those background drugs have been shown to reduce the incidence of hyperalgesia when using intraoperative opioids.
All important considerations. Can you use remifentanil in IV conscious sedation by a non-anesthesia provider?
I'm going to say no.
No.
And I think
But that's a good question.
It is an excellent question.
Because it seems like this would be the ideal, and I think when this was launched many years ago, certainly gastroenterologists, bronchoscopists, and non-anesthesia providers thought this would be a great drug to use.
because of rapid onset,
Because
rapid offset.
But we've already alluded to the fact that the rapid on can cause life-threatening bradycardia, hypotension, apnea, chest wall rigidity, laryngospasm. The rapid off can cause catastrophic tachycardia and hypertension, and you need skilled providers to administer remifentanil, period.
You had talked earlier when we were in rehearsal about patients being in control of their life and their care. Do you remember that conversation?
Yes.
Would you talk a little bit more about that? Because I think it's an important component about we have control of the patient during surgery, but how quickly we're able to give that control back to them is critical and dependent on the drug we use, right?
Absolutely. That's usually my goal at the end of the case, is to return control of the life to the patient immediately post-op, as soon as possible, so that they can tell us that they're having pain, that they can tell us that they're having respiratory issues, that they can converse with us and tell us what's going on. Even the smallest child can, through facial expressions, tell you what's going on with them. So it's important that we're able to do anesthesia that they can wake up and take control, because during the whole surgical procedure, we're controlling their heart rate, we're controlling their blood pressure, we have control of their lives, and it's important that we return that to them as quickly as possible so that they can be discharged home quicker. Even if it's an inpatient, they can be discharged to their room floor quicker and have control and interact with their family and loved ones.
What is the disadvantage of TIVA?
So, I mean, one of the major disadvantages is that it's labor intensive. You have to set up an infusion pump. Sometimes some would advocate even having a separate intravenous line specifically for the IV drugs. So if you're planning to give a large fluids through another intravenous route, some advocate having a second line specifically for the infusions. There's a lot of syringes, a lot of reconstituting. So remifentanil, if that's part of the TIVA, has to be reconstituted. It's the only opioid that we have that comes in powder form, and you have to reconstitute it into usable fashion. But it is terribly labor intensive, which is entirely worth it when you can control the anesthetic intraoperatively and watch how lucid, cooperative, just the sense of well-being our patients wake up with having received this. Personally, I was on the receiving end of a total intravenous anesthetic, and I know when I woke up after my urgent surgery, I had a great sense of well-being about my caregivers, about the institution, and I felt great afterward, and I would advocate if I'm willing to give it to, if I'm willing. So I think there's a lot of hypocrisy, and we'd ask anesthesiologists, what are you giving your patients? What would you want for yourself? And my guess is a lot of practitioners would want IV-based anesthesia for themselves, yet it is a lot of effort. We did allude to the cost. It is more expensive. But again, we're talking unit by unit. You can't calculate the uncalculable, it's a really terrible word, savings and the satisfaction of the patients.
But there's also the total care process, not just the drug, correct? It's
Correct.
how long they're in the PACU, all the labor that goes into that, complications, and it's a lot harder. The business case for the entire stay is what we need to be paying attention to.
Absolutely.
Correct.
One more quick one, and I think we're almost out of time. What's the key to titratability?
The key to titratability is to be able to take your patient where exactly you need them quickly. If they're having
that individualization?
Individualization of their care, because every patient's different. You may think that if you give 100 mics of propofol to put somebody to sleep, that they're going to go to sleep, but it may take them 200.
Right.
I may start remifentanil at 0.1 mics per kilogram per minute, but someone even your size could be at 0.2 mics per kilogram. Everything's individualized.
So again,
and so I can then titrate it to exactly what my patient needs to keep them comfortable. And through that titratability, I can keep my patients normal intensive and keep them normal where they need to be.
It's a great way to end the conversation. It's back to that unpredictability of the patient. We've covered a lot of ideas about current anesthesiology practice here in today's program. So if we could remember only one thing, what should it be? Adam?
I mean, I think we all believe that what we're doing intraoperatively is very transient, and as long as we did a great job intraoperatively and kept the patient hemodynamically stable, they're going to do fine postoperatively. I think we're deluding ourselves. I think it behooves us to use, first of all, have an armamentarium of drugs, know your science, be able to hand select the drugs and the techniques for the specific patient, but it certainly behooves us to minimize the exposure of our patients to these pharmacologic agents. The data is still evolving, but it's pretty clear that many of our drugs are not just inert, they go in and go out, that they might have long-term residual effects on our patients. And it certainly behooves us to use technologically engineered drugs that can minimize the use of those other drugs and also itself dissipates, eliminates, and is not residually still affecting our patient in the acute perioperative period.
Thank you. Mark?
Don't stop learning.
Good.
You have to trial everything we have available to us because one specific drug is not correct for every patient. And so we got to continue to learn and do what's best for our patients and for their care.
So being a lifelong learner is the best lesson.
Absolutely.
Let's briefly review our learning objectives again and the key points you should remember about our discussion today. Our first objective, discuss the considerations for perioperative anesthesia with short-acting opioids. You should understand opioids' pharmacokinetics and the pharmacodynamics, understand cardiac stability, and that they're used to reduce MAC. Our second objective, examine the pharmacokinetic and pharmacodynamic effects of available short-acting opioids used in general anesthesia. There are 4 key effects. Remember, cardiovascular stability, reduced hypertension, unique onset, offset, and organ independence for elimination. The third objective we discussed, describe the advantages and disadvantages of short-acting opioids as part of a general anesthesia regimen. These include reduction of MAC, titratability, predictability, but be aware of the side effects. Since we're almost out of time, I'd like to formally thank Mark and Adam for bringing their unique expertise to today's compelling topic. And thanks to Randall Martin and Channing Bryant for allowing us to interview them and hear their important perspectives. But most of all, thank you for taking time out of your busy schedules to join us. We know this is an important time for you, for us, and for our patients. We're all striving to make leading practice common practice. If you'd like to receive continuing education credit for participating in today's program, please register and complete the program evaluation online. It's really easy. From VHA TV, I'm Lily Jelinas. Thank you for watching.
This program is supported by an educational grant from Mylan.